and postgraduates. Now, today we have a very important topic of treatment of chronic liver disease, management of chronic liver disease. For this, we have a very eminent speaker, uh, Sujit Chaudhary, and who will be introduced by our one of the directors, Professor P.S. Kormokar. Partho, please introduce.
Acha. Thank you, Professor Sarkar. Uh, Today we are already said by Professor Sarkar that we are having a very important topic. So far, our postgraduate students are concerned, they will definitely love it and they will definitely be benefited. And today this session will be chaired by our very beloved API members, as he is an astute physician and senior gastroenterologist of repute. At present, he is attached to Manipal Broadway Hospital, and he is head of the department over there in the Department of Gastroenterology. And by the way, he is also my batchmate. We did our MD as well as house job sheet together. So he's a very good friend of mine. So with this short introduction, I hand over the mic digitally to Dr. Sujit Chaudhary to introduce our
Okay.
speaker as well as start the procedure. Over to Dr. Sujit Chaudhary.
Thank you, my beloved friend, Dr. Partha Kormukar. And I thank you all the senior faculty members who are joining this webinar. So, Dr. Sarkar told that, okay, I am chairing the session. I will be conducting, but the speaker is our bright gastroenterologist, Dr. Sanjay Bandyopadhyay. And he is a well-known gastroenterologist in Kolkata. I think that he needs no introduction, but just to say a few lines about Dr. Bandyopadhyay, he is a senior consultant gastroenterologist. He is now attached to ILS Damdam, Kolkata, and he is also a teacher of the DNB course in gastroenterology in ILS Damdam. So he is a very good clinician, and he is not only gastroenterologist, he's a good internist. And I am proud of him. From my college, and though we have not worked together, but when I was at PG, then after that he did DM in gastroenterology. So Sanjay has a lot of international and international publications. He is also the secretary of developed it as a pancreas club in Kolkata Pancreas Club, and he is doing yearly CME yearly meeting. And with this short introduction, I want to invite Dr. Sanjay Bandyopadhyay. He will be speaking on today the main topic of this today's program is chronic liver disease, the management of chronic liver disease. And this is just is a that the compensated and decompensated is the two important clinical spectrum of cirrhosis, that is chronic liver disease. But when we are managing compensated, how we can optimize the therapy, how can we reduce the risk of decompensation so that we can, if the patient is compensated, there is no risk for life, there is a prolonged life. But once decompensation starts, the patient death rates. So decompensated cirrhosis is totally different. But there is another entity that is called compensated advanced chronic liver disease. So that is the main topic of this today's discussion. So without wasting much time, I am requesting Dr. Bandyopadhyay to start his lecture.
Thank you, Tulita, for this nice introduction. Am I audible? I think yes.
Yeah, you are audible.
So my topic is as elaborated by my chairperson, that's compensated advanced chronic liver disease. Now, we have been treating and dealing with chronic liver disease. We know most of the cases of advanced chronic liver disease come to the hospitals. And this concept of compensated advanced chronic liver disease is quite new. This has been mostly introduced by Bevino group who are the group who periodically revise and give guidelines for management of patients with portal hypertension. And this is a group which is the focus of today's discussion, which is a focus of our usual treatment, because at this stage, some of the therapies may meaningfully alter the outcome of disease. Otherwise, most of them land up in decompensation, transplantation, or death. Let us start with the case. It's a 45 years old non-diabetic alcoholic male who presented with fatigue and pruritus for last 3 months. The fatigue was progressively increasing, but there was no demonstrable muscle weakness. The pruritus was mostly marked at night, disturbing his sleep, but there was no specific skin lesion, and it was generalized pruritus. Patient also complained of insomnia since the cessation of alcohol intake, and often there were muscle cramps at night, spontaneous, disturbing the sleep even further. With all this complaint, patient came to us, but there was no history of ascites, no pedal edema, no altered sensorium, oliguria, bleeding manifestation, or gastrointestinal bleeding, what we usually encounter in this sort of patients of alcoholic coming with the symptoms. On examination, patient was jaundiced. There were scratch marks suggestive of pruritus. There were multiple spiral angiomas, usually around the neck and upper chest. Liver was palpable, firm, undulated margin. Spleen was firm and enlarged, and patient was overall undernourished. Now, initial laboratory parameters showed a normocytic normochromic anemia, low albumin of 3. The bilirubin was raised, 2.5. All the liver enzymes almost raised, SGOT, SGPT, alkaline phosphatase, as well as GGT. The imaging findings showed a heterogeneous liver with liver size reduced, portal vein dilated up to the extent of 14 millimeter. There was splenomegaly, there was collaterals at splenic hilum. All this suggestive of chronic liver disease with features of portal hypertension. But there was no ascites, there was no SOL, no portal vein thrombosis. Patient did not have edema. There was no history of gastrointestinal bleeding. However, screening endoscopy showed a low-grade varix, that is less than 5 millimeter, grade 1 to 2 varix as reported. So this is the case what we got. Now, in our common day-to-day practice, particularly in the hospital setup, we are more comfortable or accustomed seeing patients of liver disease who come with ascites, variceal hemorrhage, hepatic encephalopathy, jaundice, and with multiple organ failures, most of these sometimes precipitated by bacterial infection or GI bleeding. So I think most of the students of medicine are also accustomed and they have been trained thoroughly to deal with such cases, to decide about their treatment policy, to think about the differential diagnosis and how to bail them out from these complications. Interestingly, a part of chronic liver disease which roams freely in the community, perhaps do not present with these complications and do not come to this hospital, still they harbor the liver disease. And this stage is called compensated liver disease or compensated cirrhosis for that matter, which precedes this decompensation events. And because in these stages, there is architectural distortion of the liver that our patient had, features of portal hypertension that our patient had, though they may not be a bleeder, there are some systemic inflammation, immune deficiency, predisposing them to infection as well as gut dysbiosis. And treating at this stage with the causal treatment of the causal agent or treatment of environmental factors like alcohol or obesity or genetic factors may help preventing their progression into decompensated stages. And those who are practitioners and students of medicine need to be accustomed or need to be briefed about this peculiar phase in the natural history of chronic liver disease, because management or some control measures at this stage may improve the outcome. So patient goes from compensation to decompensation stage when hepatic venous pressure gradient progressively increases and achieves a mark of 10 millimeter mercury. However, in practice, nobody measures hepatic venous pressure gradient. Rather, we have fibroscan at our hand. To any patient showing a fibroscan value of 15 kilopascal, we assume that this patient is possibly having a chronic liver disease, which is at present at compensated stage. And when the fibroscan values, and these fibroscan values are very good surrogate marker of hepatic venous pressure gradient, which are difficult to obtain. When these fibroscan values cross a mark of 25 kilopascal, this almost always confirms that patient is having compensated advanced chronic liver disease. And from this compensated stage, Then the patients go on developing features of decompensation like ascites, encephalopathy, or bleeding. So overall spectrum of chronic liver disease has 3 stages, and the changes or pathophysiological changes progressively accumulate as the disease progresses. So in stage F1, F2, F3, patients are usually symptomatic. Patients don't come to us. In stage F4, we call it cirrhosis. However, in cirrhosis, there is a compensated phase and there is a decompensated phase. Now, the term cirrhosis has been replaced by advanced chronic liver disease. So we call it compensated advanced chronic liver disease and decompensated advanced chronic liver disease, respectively. However, diagnosing this compensated advanced chronic liver disease is difficult because, as I said, they don't have ascites, edema, history of GI bleed, fetal edema, oliguria, history of hepatic encephalopathy, like these things. So, diagnosis mostly relies on investigation findings. They have high hepatic venous pressure gradient, suggestive of clinically significant portal hypertension. Now, they have high transient elastography value of more than 25 kilopascal. Endoscopy shows varices. Platelets may be low. On USG and Doppler, they have altered morphology, splenomegaly, portal hypertension, and hepatofugal flow. Now, coming to our case, our patient mostly fits with this diagnosis of compensated but advanced chronic liver disease, where this patient has predominantly an imaging findings and the symptoms were mostly non-specific. However, even at this stage, there are certain issues which impact the quality of life of the patient. These issues are fatigue, depression, pruritus, the fear of bleeding, cramps, sleep, sexual dysfunction. These are the issues which are often unnoticed or undetected in clinical practice, apart from ascites and hepatic encephalopathies and more common symptoms. But studies have shown that they can significantly impact the quality of life, as our patient also presented for last 3 months with most of the symptoms like fatigue, pruritus, insomnia, and muscle cramps, which most of the clinicians will not take in seriously because they are not the telltale signs of so-called advanced chronic liver disease. But they significantly impact quality of life, and quality of life is a marker of hospitalization in patient of cirrhosis. Some of these patients are admitted in the hospital for the control of their symptoms, increasing the cost of therapy. And even this poor quality of life is a marker of relative risk of death because some of these patients, because of pruritus, because of insomnia, may sometimes commit suicide or resort to certain antidepressant medications. So coming to our case, what could be the cause of fatigue in this patient? Now, fatigue is one of the most commonly encountered symptoms in chronic liver disease, though this has classically been described with primary biliary cholangitis or previously called primary biliary cirrhosis. This is one of the common symptoms across the entire spectrum and across the entire, irrespective of the etiology of chronic liver disease. The fatigue can have a peripheral component, which is usually reported by patient like reduced power, myalgia, or worse recovery from an infection. But it also has a significant central component like reduced motivation, poor memory, and poor concentration. Now, the differential diagnosis of fatigue in a patient of chronic liver disease is broad. This could be pre-existing psychological disorder. Some of the medications like beta blockers and muscle relaxants given for muscle cramps and even benzodiazepines taken for insomnia may also cause fatigue. The patient may have associated metabolic disorders like hypothyroidism or hyponatremia, or there may be superimposed viral infection because they are immune suppressed. They can have associated tuberculosis or superimposed viral hepatitis on a chronic liver disease. Now, anemia of chronic liver disease could be a cause of fatigue, or fatigue may be an initial symptom of underlying occult hepatocellular carcinoma. So there is a fourth step in the clinical approach of fatigue. In any patient who is presented with fatigue, our first thing that clicks our mind whether this is a case of primary biliary cirrhosis or not, because primary biliary cirrhosis needs separate treatment. If primary biliary cirrhosis is or primary biliary cholangitis now it is called is ruled out by antimitochondrial antibody estimation, then in the second step we rule out medication use, endocrine abnormalities like hypothyroidism, dyslipidemia like hyponatremia or hypokalemia, and other superimposed viral infections. If all these are ruled out, in the third stage, a superimposed tuberculosis like CT thorax, mantus, or IGRA, or a superimposed hepatocellular carcinoma like triphasic CT or dynamic MRI plus minus AFP needs to be ruled out. If everything is ruled out, then what remains is fatigue of chronic liver disease that is often difficult to manage. And we have very little therapeutic options for management of this fatigue. The usual trace, or you can call trace approach for management of fatigue of CLD encompasses four issues. One is we have to treat the treatable. If it is hypothyroidism, if it is anemia, if it is because of superimposed viral hepatitis, we have to treat in the best possible way. But we have to ameliorate which is not treatable, like sleep disturbances, like itch, like depression, like avoidance of the drugs. And we must help the patient to cope with the existing symptoms, to develop a coping strategy so that psychological help or physical activity and improvement in the diet may help to some extent to ward off the fatigue. Finally, we must empathize with the patient and encourage them to be optimistic. Don't fail before you start. Apart from fatigue, one another symptom that our patient had was pruritus, and this pruritus was marked at night, disturbing his sleep. Obviously, on investigation, there was nothing suggestive of biliary obstruction or cholestasis. It was a case of alcoholic with pruritus. 10% of all alcoholic liver disease are cholestatic, and this cholestatic alcoholic liver disease has a worse outcome compared to the non-cholestatic usual hepatocellular chronic liver disease related to alcohol. Now, see, how can we approach this pruritus? Pruritus is often a disabling symptom in chronic liver disease because most of them have intense nighttime itching. This is because of some changes in the endogenous opioidergic system. The pruritus is usually in most of the patient more at night. And this pruritus is often worsens the fatigue, and pruritus often deprives the patient from the adequate sleep. And because of subjective nature of pruritus, there is an added difficulty in determining its etiology and severity. Now, we usually assume that an elevated serum bile acid is responsible for these pruritus because they stimulate the so-called itch signals and the higher center is at hypothalamus. But studies have not shown any good correlation in chronic liver disease, at least with the serum bile acid. So there are possibly other putative pathways or agents which are responsible for pruritus in chronic liver disease. One of them could be prostanoid X receptor agonism by interleukin 31, or maybe some of the PPAR alpha and gamma transcription factors. Now, differential diagnosis of pruritus is also broad because patient may have skin disease like predisposed to low immunity, and alcoholic may develop fungal infection. The patient may have concomitant systemic disease like diabetes, iron deficiency anemia, CKD, or maybe iron therapy can cause pruritus as a side effect. The pruritus could be psychogenic, or there are some drugs like penicillin given or tetracycline or metronidazole given in patients with chronic liver disease. Sometimes beta blockers, opioids, and antidepressant statins can also cause pruritus. The clinical approach patient of pruritus with compensated advanced chronic liver disease, we have to first rule out the dermatological and systemic factors. And there are scales to objectively measure pruritus because pruritus is often a subjective symptom and difficult to assess. So this is called visual analog scale, but more appropriate than is a 5D itch scale. This evolves around 5 points, and there is a marking from 5 to 25. 5 is no pruritus, 25 is most severe pruritus. Suffice it to know that there are objective scales for pruritus, and visual analog scale is mostly used, but more scientific would be 5D itch scale. There is a specific scale for PBC called PBC pruritus scale. This is for postgraduates. Now, how we manage the pruritus? Worldwide, ursodeoxycholic acid is commonly used to manage the pruritus. However, pruritus of cholestasis as well as pruritus of chronic liver disease is perhaps best managed by cholestyramine or cholecebulin, which are bile acid binding agent which work in the intestine. They bind with the bile acid, so enterohepatic circulation is stimulated, more and more bile acids are excreted, thereby suggesting that bile acids perhaps has a role in pruritus. However, the side effects are that they are very costly in India and they have unpleasant taste. The pregnoid X receptor, the commonly used drug rifampicin in tuberculosis, is also a good enzyme inducer. It can help in pruritus. When bile acid binding resins are not working, we add rifampicin. Now, apart from management of pruritus of intrahepatic cholestasis of pregnancy, perhaps UDCA has no role in the management of pruritus of any other etiologies of liver disease, be it intrahepatic or extrahepatic. So the first line agent is bile acid binding resin, but if there is no improvement within 2 weeks, we use rifampicin in a dose of up to 6 milligram per day. There are other alternative therapies like naltrexone. Naltrexone is presently available. So naltrexone is sometimes used in alcohol dependence disorder. Sertraline may be helpful in pruritus, and there are some experimental therapies like gabapentin or pregabalin and other PPAR alpha gamma agonists. So first we use bile salt binding agent. If no response, then rifampicin. If no response, then naltrexone, and if no response, then certainly now you might consider these experimental approaches, including gabapentin or pregabalin. So coming to the third symptom which is affecting his quality of life is insomnia. So our patient, since cessation of alcohol, is insomniac, and it is very prudent to consider that he is perhaps having alcohol withdrawal syndrome, but 3 months is too long for this alcohol withdrawal syndrome. However, in any patient who complains of insomnia and is an alcoholic, 60 to 8% of overall alcoholics, even unrelated to alcohol withdrawal, they report subjective poor sleep. But key contributors to sleep disturbances, and we must be alert to these possibilities, is that early hepatic encephalopathy. So any patient complaining of sleep disturbances, even if in compensated stage, we must think of hepatic encephalopathy. And most of the cases, this poor sleep is due to altered melatonin metabolism. And frequent presentations are patients are either insomniac, or they have increased sleep latency, or they have reduced time in rapid eye movement sleep, which is a refreshing sleep. So they are not refreshed even after their adequate hours of sleep. But the most important thing, and which impairs quality of life, including their driving capacity, as well as attending any meeting or day-to-day activities, is excessive daytime sleepiness. Because they are insomniac, so they have excessive daytime sleepiness. And this is the point which usually affects the quality of life maximally, because this interferes with driving, this interferes with learning, this interferes with regular day-to-day activities of the patient. Now, hepatic encephalopathy is always a differential diagnosis of insomnia in a patient who is chronic liver disease. Alcohol withdrawal or delirium tremens are also possibilities. However, if the history is long, we must consider of other things like drugs, opioid, antidepressant, beta blocker, sleep disturbances, or restless leg syndrome, or obstructive sleep apnea, particularly if the patient is obese. Now, differentiating between alcohol withdrawal, warning encephalopathy, and hepatic encephalopathy is very important, because all of them can present with altered sleep, or maybe in extreme cases, acute confusional state. Alcohol withdrawal classically occurs 2 to 4 days after cessation of heavy intake. Warning encephalopathy usually occurs in persons who are consuming alcohol and alcohol only, and frankly, no calorie. So alcohol stoppage, alcohol withdrawal, presentation is confusion. Excessive alcohol, no food, warning encephalopathy, presentation again with confusion. And hepatic encephalopathy is usually a differential diagnosis of all. The characteristic features of alcohol withdrawal is hallucination. The characteristic, along with autonomic symptoms and tremor. The characteristic features of warning encephalopathy is delirium, global confusion, disorientation, and apathy. Whereas characteristic features of hepatic encephalopathy is hyperventilation because of stimulation of the pneumotaxin apneic center. Alcohol withdrawal is usually short-lived, and they respond to benzodiazepine. Warning encephalopathy responds to high dose of vitamin B1, and hepatic encephalopathy responds to lactulose and antibiotic. In alcohol withdrawal, there is decreased GABAergic activity, and in hepatic encephalopathy, we all know there is an elevated ammonia. In warning encephalopathy, the neural transmission is defective because of deficiency of vitamin B1. Now, useful measures to treat this sleep disorder, we have to treat the potential causes. If the patient is having pruritus, cramps, or sleep apnea, then we have to treat that. We need to adjust the dose of diuretics or lactulose. There will be some non-pharmacological means, like they should avoid afternoon naps or caffeinated drinks late in the night. The pharmacological therapy, zolpidem is safe in a dose of 5 to 10 milligram, but the pharmacological therapy which we have seen most useful in this sleep disorder of chronic liver disease is melatonin 3 milligram, given usually in the evening. However, in alcoholics, trazodone 50 milligram, which is antidepressant, is also useful, and it does not have significant impact on liver function. Now, coming to the fourth point, which is troubling our patient and is contributing to his insomnia, is a muscle cramp. Now, muscle cramps are involuntary painful contraction, and in our life, almost all of us has experienced muscle cramps towards the end of our sleep cycle. But they are usually self-limiting, even in chronic liver disease. So there is perhaps some impaired energy metabolism or some change in the plasma volume and electrolytes, which are the proposed pathophysiological mechanisms for muscle cramps in advanced chronic liver disease. However, in any alcoholic, if you have muscle cramps, the neuropathy, like peripheral neuropathy of alcoholic neuropathy, or particularly if the patient has concomitant kidney disease on dialysis, or medications like diuretics or beta blockers, because diuretics can precipitate muscle cramps by hypokalemia, or occult malignancy should be ruled out. Thorough clinical history and physical examination is important, and these muscle cramps should be differentiated from other neuromuscular disorders like myositis or motor neuron disease by the absence of pain, fasciculation, or other signs of inflammation. The muscle cramps of chronic liver disease are usually spontaneous. The benign muscle cramps, which we all experience in our life during our sleep, occurs usually at the when we stretch our legs. But muscle cramps of chronic liver disease are not stimulated by stretch. They are spontaneous. They are chronic and they are nocturnal. So electrolytes should always be checked, like hypokalemia or hyponatremia, and corrected if low. And you will be surprised to know there is a cramp questionnaire composed of 10 points, and this is very useful in most of the patients with muscle cramps. The pathophysiology of muscle cramps is the neurons are hyperexcitable because of some toxins which are not which are usually excreted by liver or metabolized by liver are not excreted properly, or there may be some an abnormal energy metabolism, and there is a decrease. Studies have shown that there is decreased plasma concentration of taurine. Taurine is the most important amino acid in skeletal muscle, and there is proposed mechanisms of zinc deficiency in the causation of muscle cramps. Based on these proposed pathways, the therapies have been devised. Overall, in muscle cramps, I think physicians and neurologists use quinidine. Vitamin E in dose of very high dose of nearly 600 milligram per day has also shown to improve muscle cramps. But the choice of drug for most of us hepatologists is zinc and taurine. Now there are formulations of taurine which are available. They are often given along with coenzyme Q, zinc or vitamin E in a cocktail formulation, and that are very useful to control the muscle cramps. Now, apart from this improving quality of life, like improving the symptoms or controlling at least the symptoms of pruritus, muscle cramp, insomnia, etc., improving survival is another facet of managing the patient is compensated advanced chronic liver disease. Because in compensated advanced chronic liver disease, the median survival is 10 to 12 years. Whereas even with a single decompensation, how effectively you treat them, median survival is 1 to 2 years without liver transplantation. And once decompensation occurs, the approximately 85% will die within 5 years. Such is the significance of even a single episode of decompensation in a patient who is compensated advanced chronic liver disease. So improving quality of life at the compensated stage is important. Improving survival, or rather in a better term, preventing at least decompensation at this stage is also important. So this is another facet of approaching the patient of compensated advanced chronic liver disease, that we must work hard to devise ways and advise them how can they prevent decompensation. So the usual precipitating decompensation events, most of them decompensate at ascites. So the commonest decompensating event in a history of chronic liver disease is ascites. The second common is variceal bleed, often precipitating ascites. Third common is hepatocellular carcinoma. Most of these ascites and variceal bleed are even precipitated by infection, either bacterial like pneumonia or by viral like viral hepatitis. Those who are actively consuming alcohol, the alcohol itself could be a precipitating factor. In some of the cases, gastrointestinal hemorrhage is the first decompensating event, or some hepatotoxic drugs or drugs given by alternative system of medicine are often the precipitant. They present with acute or chronic liver failure, but somehow that becomes a decompensating event. So what are the interventions that can prevent this decompensation? Let us take one by one. Now, infections like pneumonia could be prevented or intervened by vaccination against influenza and pneumococcus, whereas superimposed viral hepatitis can be prevented by vaccination at least against hepatitis B. Now, for hepatitis B, all patients of compensated advanced chronic disease should, and I repeat, all patients of advanced chronic liver disease should receive hepatitis B vaccination. Now, hepatitis A vaccination is mandatory in Europe and United States. Over the years, the government of India has lost interest in promoting hepatitis A vaccination even in children. So we are now giving hepatitis A vaccination to almost all patients of chronic liver disease who are B negative but has a risk of hepatitis B. And early you give this vaccine in the course of the disease, better is the response. The standard is 3 dose, 2 dose is not available in India. Standard is 3 dose, standard adult dose 0, 1, 6, like what you and we all take 0, 1, and 6. However, there are proposals that patients with chronic liver disease, because they are immune suppressed, they should get a double dose. Pneumococcal vaccination, all patients should receive 1 dose of this PCV13, which is total 13 antigen pneumococcal conjoined vaccine, followed by doses of polysaccharide pneumococcal vaccine. Polysaccharide pneumococcal vaccines are usually repeated every 5 years or repeated once the patient attains an age of 65 years. Influenza vaccination is recommended, and this is with inactivated influenza vaccine. We usually avoid live vaccines or live attenuated vaccines in chronic liver disease because they are immune suppressed. Influenza inactivated vaccine for all adult patients, at least one dose annually before the winter. Zoster vaccination is usually not recommended. There is no guidelines to suggest that. But see, despite strong recommendations, the vaccination coverage even in Western countries is close to 30 to 40%. In India, the situation is even dismal. In recent years, however, since COVID, people's awareness and coverage against influenza and pneumococcus vaccination in every disease, including liver disease, has shown some improvement, and COVID is responsible for that. But the cause of low immunization is inadequate access to healthcare, lack of information that vaccines are needed, and vaccines are safe in liver disease. And in India, we have now problem with hepatitis A vaccine, procuring this vaccine. There are factors like those who are in advanced stage of the disease, obese diabetes, they usually respond poorly. And those who respond poorly, there are strategies you can give, either accelerated vaccine regime like 0, 1, then 2, and then 12 months in place of 0, 1, 6, or more appropriate is increasing the vaccine dose from the very beginning. If you think they are unlikely or going to respond, increase the dose from standard adult dose, which contains 20 microgram of Engerix B, to 2 milliliter on each dose, 2 milliliter 0, 2 milliliter 1, 2 milliliter at 6 months. Seroconversion rate is, however, is not as good as in normal person. Up to 80% the seroconversion rate. So you have to check the antibody titer at least 6 months after the final dose is given. Now, coming to another way of preventing the decompensation, we can prevent gastrointestinal bleeding in patients who have varices with beta blockers or endoscopic band ligation or endoscopic variceal ligation. Now, coming to our patient who had 2 columns of grade 1 to 2 varices, I think Professor Sujit Chaudhary will also agree that grade 1 and 2 varices less than 5 milliliter non-bleeder are not cases for endoscopic band ligation. So, what option we have is beta blocker. Now, beta blockers has been classically, and they have a very established role in prevention of fast bleeding in large varices and prevention of rebleeding in patient whose varices has previously bled. So any patient who has large varix, more than 5 millimeter, we give this patient beta blocker. And in patient who has a history of bleeding, irrespective of what treatment they have received, we do endoscopy and give beta blocker. These non-selective beta blockers initially included propranolol, lanolol, and timolol. I think propranolol was commonly used. It has been in use since last 50 to 60 years. Recently, carvedilol has been shown to be better than propranolol and all other drugs. Carvedilol is not only a beta blocker, it has intrinsic alpha-1 adrenergic activity. Basically, this is also acting as a vasodilator. It has a greater potential to reduce the portal blood pressure than propranolol. And there are studies which have compared carvedilol head-on with propranolol and has shown that carvedilol is better than propranolol. And carvedilol is safe in patients with compensated as well as decompensated chronic liver disease. Now, how these beta blockers act? Beta blockers actually, they act on beta 1 receptor, decrease the cardiac output, so decrease the portal flow. Beta blockers also act on the beta 2 adrenergic splanchnic vessels. They cause vasoconstriction, so blood is there is the splanchnic vasodilator, which is mostly responsible for increased portal venous inflow, that is tackled. In addition, this carvedilol, because it has an alpha-1 adrenergic blockade activity, so it increases the dynamic component of portal hypertension. So carvedilol also has a role, which is the role is better than standard beta blockers like Indelol. Now, new trials has shown that the beta blockers, particularly carvedilol, they are not only useful for the prevention of bleeding, they are also useful for prevention of decompensation, that is ascites, in patients of compensated advanced chronic liver disease. This is because the appearance of varix, progression of varix, as well as bleeding from varix depends on HBPG, portal pressure. Beta blockers decrease that. Similarly, whether the patient develops ascites and develops refractory ascites, that depends on HBPG. So a drug which decreases portal pressure measured by HBPG will also be useful for prevention of ascites, and that has been proved in a study called pre-disease study done by Villanova et al., published in 2019. And since then, we are using carvedilol not only to prevent varices and variceal bleeding, also to prevent decompensation in patients of compensated advanced chronic liver disease. So any compensated advanced chronic liver disease should have the advantage of beta blocker, preferably carvedilol, unless there are specific contraindications for that. Now, fixed doses of beta blockers are discouraged because those needs to be titrated. Individual susceptibility to beta blocker varies, and I think the Asian population responds to beta blockers separately from that of Western population. Their responses is usually better. Adherence and doses of NSPB should be evaluated whenever there is any significant change in clinical condition of the patient. And now there are proposals that patients with patient with refractory ascites, patient with hepatic encephalopathy perhaps need discontinuation of the beta blocker. So beta blocker has a therapeutic window. Too early may not be useful, but definitely in compensated stage, definitely in early decompensated stage, unless the patient is in refractory ascites. So only not only prevention of variceal bleeding, prevention of variceal rebleeding, prevention of bleeding from gastric varices or portal hypertensive gastropathy, or for development of varices. Beta blockers has a role in prevention of decompensation. So beta blockers has a role beyond varices. However, we need to consider the dose, reducing the dose or discontinuing beta blocker when the patient develops hypotension. With propranolol, if the patient develops hypotension and bradycardia, we decrease it. With carvedilol, patients usually do not develop bradycardia. So there is no need to check the pulse rate with carvedilol. If blood pressure is less than 90 millimeter mercury, then they should be stopped because there is very low blood pressure. And if the sodium is below 130 or maybe 128 milli equivalent per liter, the beta blocker should be stopped because perhaps the patients are going on to develop hepatorenal syndrome or refractory ascites. Propranolol should be given twice a day. I know there are long-acting propranolols, but the international recommendation is propranolol should be given twice a day with a target resting heart rate between 55 to 60 millimeter mercury, and therapy should be lifelong. Similarly, carvedilol should be started once a day, preferably around the evening time, and then changed to twice a day. Maximum dose is 12.5 milligram because with higher dose, there are arterial hypertension. Systolic blood pressure is the marker, not the pulse rate. And again, the therapy should be lifelong. So with beta blocker started at this compensated stage, and perhaps this is the one of the most accepted therapy at the compensated stage to prevent decompensation. Therapy should be lifelong unless there are contraindications. Now, coming to another way of preventing decompensation, by patients who are actively consuming alcohol, alcohol abstinence should be proposed. And patients should be supported in the pathway because studies have shown that alcohol cessation works. Patients who are discharged from the hospital, if they are abstinent, there is significant improvement in the survival. However, those who continue or those who have relapsed of drinking pattern, their cumulative survival progressively decreases compared to those who are abstinent. So abstinence does work. Alcoholic cessation is a must if the patient is consuming alcohol because that prevents decompensation. And now we have medications in alcohol use disorder, we call MOD. There are 5 medications, all available in India, but 2 which are asterisk marks, naltrexone and acamprosate, they are approved by the US FDA. We frequently use baclofen, topiramate, gabapentin in India, and we are comfortable using that. ASLD guidelines in America in 2019 says that naltrexone is not safe in liver disease. However, there is a study in 2023 which has shown that naltrexone is also safe in liver disease. However, this should be done under the supervision of a psychiatrist. Finally, coming to another way of preventing decompensation is screening for hepatocellular carcinoma, because hepatocellular carcinoma can cause a downhill course, and this is considered to be one of the feature of decompensation. Because hepatocellular carcinoma per se by portal vein thrombosis is predisposed to more and more ascites or development of large varices with uncontrollable bleeding. So every effort should be made to screen or go for surveillance for hepatocellular carcinoma. Now the modality is recommended worldwide, and we also practice in our country is liver ultrasound every 6 months along with estimation of alpha fetoprotein. Now, this is commonly practiced. This combination method has a sensitivity of only 65%. However, the specificity is high, so that if the results are normal, then you can jolly well say that patient is not harboring hepatocellular carcinoma. And even with this low sensitivity, studies have shown that they improve overall survival. Now, how to interpret the ultrasound report? Ultrasound report, if does not show any focal abnormality in cirrhotic liver, or if there is a cystic lesion, we call it negative. And if there is less than 1 centimeter of lesion, then it is called non-diagnostic. Any lesion which is more than 1 centimeter picked up by ultrasound in a patient with chronic liver disease, be it compensated or decompensated, any lesion more than 1 centimeter First possibility is HCC, second is HCC, third is HCC. Perhaps fourth is nodular degenerative hyperplasia. But before saying nodular degenerative hyperplasia, radiologist and hepatologist or physician should be 100 times sure that they are not dealing with HCC. So any lesion more than 1 centimeter on ultrasound is very suspicious. Alpha-fetoprotein alone has a sensitivity of 60% and specificity of 90%. A level, normal level is up to 5 nanogram per milliliter. A level of more than 20 nanogram per milliliter is considered positive. Most of the cases of hepatocellular carcinomas usually come with levels which are more than 400 or 500 nanogram per milliliter. However, rather than single estimation, repeat estimation or longitudinal changes in the alpha-fetoprotein may increase the sensitivity of specificity. So even on repeat estimation, if it is increasing from 20 to 30 or 45, then it is sufficient, even if it is not more than 400 or 500. So because of low sensitivity of alpha-fetoprotein, there are other ways of looking at it. So people have started with L3 isoenzyme fraction of alpha-fetoprotein. The percentage of L3 may give a good idea about the risk of hepatocellular carcinoma. Dr. Sarian's group has worked from Delhi extensively on des-gamma carboxyprothomine, that is DCP, or PIFCA, that is prothomine induced in vitamin K absence type 2. And there is recently a Gallard model proposed from Europe, which incorporates 5 points like gender, age, AFP, AFPL3, and DCP. However, they are for risk stratification. First is ultrasound and AFP. And if you think there is a mass, if the AFP is more than 20 or on serial estimation it is increasing, then for risk stratification, who is even worse? Because des-gamma carboxyprothomine, this is an abnormal prothomine. This causes coagulation of blood vessels. It causes portal vein thrombosis. So hepatocellular carcinoma with portal vein thrombosis, even worse prognosis. Are CT scan or MRI useful? Yes, CT scan and MRI has a better sensitivity at least and comparable specificity, a little better specificity compared to USG and alpha-fetoprotein. But CT has a risk of radiation exposure and MRI is not cost effective. So for surveillance, the benefits are early stage of detection and improve mortality. However, there are need for repeated or inadequate ultrasound, sometimes in presence of huge ascites in advanced decompensated stage. Sometimes the entire liver could not be seen because of fibrosis, may need towards CT, MRI, and type of 1. Finally, coming to the last point, the nutritional deficiency in alcoholic liver disease. We all know that alcoholic liver disease and our patient was also malnourished. There are many causes why nutritional disorders occur, and nutritional deficiency predisposes to inadequate immune response. So these patients are predisposed not only to the features of malnutrition, but to repeated infection. And again, infection can cause decompensation in the course of compensated liver disease. And these changes in the immunity or changes in the gut microbiota or changes in the nutritional disorders not only occurs in alcoholic cirrhosis, it starts from the stage of alcoholic hepatitis. And it's usually recommended that in alcoholic cirrhosis, even in compensated stage, should get an energy of 25 kilocalorie per kg per day with a higher protein intake of 1.2 to 1.5 gram per kg per day. And the protein should preferably intake branched-chain amino acid like valine, lysine, and isoleucine. Are vitamin, mineral, and trace element supplements, which are commonly given in alcoholic patients, are really needed? Most of the recommendations say that they can be considered if the patient is having established deficiency. Apart from established deficiency, there is no need to give routine vitamins. However, they can be, the iron is an enigma in patients of chronic liver disease. Hepatitis C or some of the alcoholic liver disease patients are basically iron overloaded. Their liver cannot handle iron, and this excess of iron is usually predisposing to hepatocellular carcinoma. However, any chronic liver disease may be iron deficient because of GI loss or marrow suppression. So in any patient of chronic liver disease, before giving iron blindly for the management of anemia, please check iron status, whether he is already iron overloaded or not, or whether he is iron deficient or not, then perhaps he or she needs iron supplement. Now, sarcopenia is an important issue nowadays and is responsible for frailty. We know the liver cirrhosis, there are many causes of sarcopenia, and this is very useful. This is CT showing skeletal muscle mass. The lower panel is normal muscle, which is shown in red. And see, in chronic liver disease, the muscle is wasted. There is hardly any muscle, particularly in paraspinal areas. And there is on muscle fiber, laminin and dystrophin staining. They are markers of muscle degeneration. There are more and more of laminin and dystrophin, and there are less and less of active contracting muscle, that is myosin. So sarcopenias, we usually give them dietary advice and exercises, and we also supplement them with high protein and branched-chain amino acid. There are some emerging drugs like in patients who are hypogonadic, they should be treated with testosterone or L-ornithine, L-aspartate, and there are some future agents. So to conclude, there are almost 10, as you can say, 10 commandments or 10 advices for patient, for physicians or students while dealing with patients with compensated advanced chronic liver disease. First, we have to treat the underlying cause. Then we have to address the risk factor. Then we have to prescribe them non-selective beta blocker, preferably carvedilol. Give them good nutritional, that is multivitamin supplementation. Avoid hepatotoxic substances. Vaccinate them with pneumococcus, influenza, hepatitis A, and hepatitis B. Uh, Ask them to exercise regularly. That will increase their muscle mass, will help preventing their fatigue to some extent. We have to screen them for hepatocellular carcinoma at least 6 monthly with ultrasonography and alpha fetoprotein. We need to educate the caregiver about these subtle changes in their symptoms and to be careful about them. And we need to monitor this condition for subsequent development of decompensation, because most of the patients, even with all best of our effort, will end up in decompensation one day or other. Thank you very much.
Thank you, Sanjay. Now, Chairperson Sujit.
They actually, so the what Dr. Sanjay Banerjee has done his job is a very good expression. Oh, sorry, and this compensated chronic liver disease, advanced chronic liver disease, that is an entity, and that is we have to take care to prevent the decompensation and to improve the survival of these patients. So he has given a very good overview, and this is the important to all the clinicians who are managing the liver disease patients. And when the patient is decompensated, there is little thing that okay, that we have to manage ascites, we have to manage variceal bleed, we have to manage hepatic encephalopathy, but the only treatment, final treatment is the liver transplantation. But if we can improve the longevity and the survival of these patients, that is compensated advanced chronic liver disease. So he has given the total overview and how that the most important things that we really not give much of importance, the nutrition part, fatigue part, the minor symptoms, but apparently it looks like minor, but that Dr. Sanjay has given that how these are so important, and so and these are the issues by which it improves the patient's survival, quality of life and survival also. So he has covered everything and this is a very vast subject. So I want that if the questions from the students, from the other faculty members, from all the, and any queries, and later we can discuss about the issues of, but more as a for the physicians, for the internist, he has given a very good overview of all the factors, and particularly what he has highlighted, that the most important thing, the nutritional part, then the beta blockers, the vaccinations, the nutritional status, and the most important ACC screening, so that you can detect ACC early, that you can treat in a treatable condition. So this is very important. So just I want that the comment from other faculties, or also the questions from the, and if I think
Sujit,
that if
একটু
there is
চ্যাট বক্সে
specialized
দেখো তো, চ্যাট বক্সে কোনো কোশ্চেন
chat
গুলো
box,
আছে?
Please go to the chat box if there is any question.
I found that only one question from Dr. Kormokar. He asked that he suggests that although the patient is jaundice, I want that Dr. Banerjee, whether we will consider that this is a compensated chronic, advanced chronic liver disease, or jaundice is a feature of decompensation.
No, see, I have mentioned the bilirubin level was 2.3. So I think at this level of bilirubin, this is not a advanced decompensated liver disease. Classically, the jaundice of liver failure is something around more than 5. Like coagulopathy of liver failure is INR more than 1.5. Though 1.2 is normal upper limit, so 1.5 is usually coagulopathy suggests to liver failure.
Yes, the age-old classification, that is child book score. The child book score, the 5 criteria. So bilirubin, only thing when it is a primary biliary cholangitis, the cutoff value of bilirubin is high. So child's A cirrhosis, what we discussed. When there is any one of the decompensation, it is either B or C. So bilirubin more than 2.5. So in a non-PBC patient, it is definitely comes to child's B. But we are more concerned about the scoring. That is the 5 and 6 is the A, and 7, 8,
7 to
9
9.
score is B, and more than 10 to 15 is C. So as a whole, but this patient definitely it is a compensated chronic, that is CACLD, advanced chronic liver disease.
There are many more questions in the Q&A box, sir.
Oh, Q&A box.
Please
Q&A
check the
box.
Q&A box.
Okay. I have
Yeah,
not
check.
checked that.
So
Okay.
I take one by
Dr.
one.
Shivendu Ghosh has what is the role of hepatitis A for decompensation? Sanjay?
Yes, hepatitis A, like hepatitis E, like hepatitis E, like hepatitis B, is a cause of decompensation. Exact prevalence or amongst them, what is the exact percentage attributable to it is not known, but it is a cause of decompensation.
And he was also asked there is a role, or what is the role of glutamine in sarcopenia?
I have not in details discussed sarcopenia because I thought in the overall perspective, I think it needs just a slight mention. There are roles, there are role of branched chain amino acid, there are role of glutamine, there are many role of L-ornithine, L-aspartate. Recently, there are studies that those who are having low sex hormones, they are given testosterone injections in child class A, in compensated stage without any damage to the liver, and they are improving. So there are many therapies of sarcopenia. But I think base therapy is give adequate nutrition, tell them to exercise, and supplement the diet with branched chain amino acid.
Another question also from Dr. Ghosh, that what stage of liver disease alcohol withdrawal is not useful?
No, this statement should not go because at every stage, our
Yeah.
effort should be please
Sure.
withdraw alcohol. Even the patient is dying, the patient is dying, and expected survival. Suppose refractory ascites, expected survival is 6 months or less. But still, then we will say that you must stop alcohol. Uh, there has not been no study that this stage alcohol withdrawal is not useful. I think it is difficult to get ethical permission for this study.
Okay. So the other thing that hepatitis A IgG antibody is necessary for giving the adult vaccination of hepatitis A. Do you want to recommend that the test for because many of our these are because of infection, hepatitis A IgG may be positive. So whether this will be a misuse of giving a hepatitis A
Yes,
vaccination?
and that is exactly the reason why government of India is also not promoting hepatitis A vaccination because of childhood infection, most person in the community is already having an IgG hepatitis A.
But I think that for hepatitis, for immunocompromised patients of particularly that is of cirrhosis, what we are discussing, that it
If
is
ever hepatitis
recommended
A and B vaccine is
hepatitis A
available, it's
vaccine
better
should
to give
be,
them.
yeah, it should be given without testing for IgG antibody. The other question is the double dose of hepatitis B vaccine. Do you recommend for cirrhosis patient?
Actually, I don't recommend because
Yeah.
we also go
There
with
is
a
no
standard.
recommendation. There
There
is
is
no
no
recommendation. Though
Now,
as
what
a
I just want to know what is your opinion?
Now, actually, there is
I
recommendation
never
for
give.
the nephrologist, but
Nephrologists give.
as a
Those who are on
whole,
hemodialysis, they give frequently.
yeah. But for
We
the
don't do it.
cirrhosis patient, according we do practice with the standard
We
dose.
don't.
Don't no double dose. But
If you
there
see
is
the
no
anti-HBS
recommendation.
is less than 10 after full vaccination, then you might think of it.
Might
No,
think,
actually,
yes.
nobody tests anti-HBS. That is the problem. Once the patient has completed the full course, everyone is happy.
Again, Dr. Shivendu Ghosh has asked that acute confusion in emergency, whether you should give thiamine immediately and whether patient is a history of alcohol and it is difficult to differentiate whether it is a alcohol withdrawal or hepatic encephalopathy. Then what is your
I think this question should
advice?
be directed to the physicians. We have not stalwart physicians in this group. In acute confusion in emergency, I don't know. Means give thiamine and then give dextrose, not dextrose before thiamine, because any patient confusion could be hypoglycemia, could be alcohol withdrawal, could be delirium tremens, anything. Means any
Okay.
patient alcoholic who is admitted with confusion, if it is an
Yeah,
alcohol
that's
admitted with confusion, we always give thiamine.
yeah.
We always, even if the ammonia level is high, we always give thiamine. If there is patient history of alcohol intake, recent alcohol intake, we always used to give thiamine.
The other question as Sanjay already has answered, that is role of anabolic steroid for sarcopenia.
Yes, yes.
I think
That I have already answered. There are roles of
already
anabolic steroid. I haven't shown all these papers because then it would have been very difficult to manage in 40 minutes.
There is no other question in the question answer box, but I can anybody can but I think students cannot ask you the question directly, but the other faculties you can ask queries. Otherwise, I think Dr. Sanjay Banerjee has done a brilliant job, and he has covered everything, and this is very, very important for clinical practice of managing cirrhosis.
And we are always talking about decompensated liver disease, and it was actually an eye opener that how physicians we should also look for subtle signs and symptoms. I would like to ask you, if a patient comes to us, is there any subtle sign to understand that this patient may get decompensated in the near future?
Predicted, yes, very good. So how can you predict that this patient is going to develop decompensation early decompensation?
So, see, the best predictor is hepatic venous pressure gradient, total pressure, which is not possible. Because only thing HBPG, it has correlation with everything, means with ascites, with varix, with variceal bleed, even with HCC. HBPG has a correlation. The best way is HBPG. But if the patient is, I think, is losing weight, his albumin is gradually decreasing, his sodium is also decreasing. I think these are some of the subtle things. He's losing weight, patient is extremely fatigued, and on repeated estimation, albumin is decreasing, sodium is decreasing, bilirubin is rising. Perhaps then he is going further down, means from child A to child B or child C. We must be very careful about the clinical examination, and that is essentially the reason why even with a normal person of compensated advanced chronic liver disease, every 6 months of ultrasound, apart from hepatocellular carcinoma, may show an ascites at an early stage which is not detectable by clinical examination. So I think
Okay.
patient who
The
is
most important the parameter is the portal hypertension. As the portal hypertension progresses, the patient becomes
everything
gradually
goes up.
decompensated. So the fast
And total hypertension
decompensation,
best is determined by HBPG, which is not possible.
HBPG, that is not actually, you cannot, but apparently, as you have mentioned, that non-invasive method, number one is the fibroscan,
Fibroscan.
then the platelet count. The
The
most
platelet is
important
also decreasing. That is
platelet
also
count
important.
is the
Very
platelet
important.
count, and that so these two parameters are very important: platelet count and the fibroscan.
Fibroscan, they are
And the
also important.
endoscopy, if
Mostly
you
they
are
are
going for
investigation
invasive,
parameters.
the
I think
varies.
what Professor Nandini is asking for clinical parameters. I think patients are extremely fatigued, losing weight. That could be one of the clinical points. Otherwise, it's mostly investigation based.
Increasing ascites,
No, ascites is
Then it is
decompensation, sir.
decompensation. No?
decompensated.
Ascites is
Okay,
decompensation.
decompensated.
She's asking compensated stage.
Compensated. Okay. So I think we have covered all important questions, and Sanjay did a very nice job. And Sujit, you have any concluding remark?
Now, concluding remark is that is most important. We should stress more and more that when we are managing a patient of liver disease, the patient has come with a liver disease. We should think of what Sanjay has repeatedly highlighted, that we should think of the caring of the nutrition, caring of the minor symptoms, how the sleep disturbances, then the muscle cramps. These are very important issues. And the other thing that these two another important that this vaccination, then the protocol for this the screening protocol for the HCC. Any patients of compensated cirrhosis apparently absolutely fine. Suddenly, if you are that is not on follow up, suddenly he found an ultrasonography has been done and there is a large mass in the liver, and then the patient will die after within few months. So this is so important. So these are the always we try to, and we do practice in that way, but sometimes most of our patients in a tertiary care center, the patients of advanced liver disease are coming to us, but physicians definitely are managing of these patients. So we should keep these points in mind. The vaccination is very important, nutrition and pruritus. These are these, I think that. And the other thing, the etiology. Etiology is also important. The occult, whether there the patient alcohol. We know alcohol and obesity is the most important disorder of chronic liver disease at present. So, but the hepatitis B, hepatitis C, then the autoimmune liver disease, there's a primary biliary cholangitis. So all the test has to be done when a patient a patient has come to us as features of just fatiguity, but an ultrasound showing that mild liver echo texture is altered, borderline splenomegaly. So this is probably that you have to detect this chronic liver disease very early. So these are I think suggestion, right? Otherwise, I think Dr. Sanjay has done a very good job, and he has cleared all the queries, and also in a very broad subject, he covered in a very elegant way.